Fragile X syndrome occurs in about 1 in 4,000 people, and it's a trinucleotide repeat disorder of CGG trinucleotides. And it's a trinucleotide repeat disorder of CGG trinucleotides in the gene FMR1. This gene is on chromosome X and stands for Fragile X mental retardation 1. The product of this gene plays a role in brain development. This trinucleotide expansion ultimately results in increased methylation of the gene, which decreases expression of the gene and also affects the chromosome structure, which gives it a fragile appearance on microscopy. That said, nothing is actually fragile in this disease, so it's kind of a misnomer. You can first recognize this in a patient with a long face and a large jaw and everted ears, which you can see in this patient. And these patients will also have autism and macroorchidism and are predisposed to have mitral valve prolapse. This is a list of the most common trinucleotide repeat disorders. They can be inherited in a variety of ways. For example, Huntington is autosomal dominant, and Fragile X is X-linked recessive. The number of repeats expands in the female germline, so when these diseases are inherited from a female parent, they exhibit anticipation, which again means that the age of onset is earlier in successive generations, or the symptoms are more severe. You should memorize the actual 3-letter trinucleotide repeat sequences, since this may help you answer questions on the exam. There are a couple really useful mnemonics in the book to help you remember both the diseases and the repeated sequences, so I recommend using those. As far as the characteristics of the individual diseases, they're all covered in more depth in other places, so I won't go through them here. Autosomal trisomies occur when 3 homologous chromosomes are present in a zygote, rather than the normal set of 2. So what I'm showing you here is a normal karyotype in which you can see 2 copies of each chromosome. But if there were 3 copies instead of 2 for any of these, that would be a trisomy. By the way, do you think this is a male or a female karyotype? So this one's from a male, which you can tell because the last chromosome in the bottom right corner here is the sex chromosomes, and one is much smaller than the other one. So this is the X chromosome and this is the Y, which means this person is a male. So how does a trisomy happen? This can be caused by one of several possible errors during meiosis. Non-disjunction is when chromosomes fail to separate during meiosis. So non-disjunction during meiosis 1 will result in both homologous chromosomes ending up in one gamete. And non-disjunction during meiosis 2 can result in having 2 sister chromatids end up in the same gamete. Chromosomal translocations, which I'll talk about in a couple minutes, can also result in autosomal trisomies. The 3 most common trisomies are trisomy 21, or Down syndrome, trisomy 18, or Edwards syndrome, and trisomy 13, or Patau syndrome. Trisomies of the other chromosomes are not viable. Down syndrome is the most common, with a prevalence of 1 in 700 people, and is the most common cause of intellectual disability. Patients often have several classic characteristics, including flat faces, prominent epicanthal folds, which are the folds of skin on the medial aspects of the eyes, and a single palmar crease, which means there's only one fold of skin across the palm. They can also have a gap between the first 2 toes, duodenal atresia, and congenital heart disease. And they have an increased risk of acute lymphoblastic leukemia. Lastly, these patients have an increased risk of Alzheimer's disease, which they can get at younger ages. The most common cause of Down syndrome is meiotic non-disjunction, which becomes increasingly common with advanced maternal age. At the age of 20 or younger, this non-disjunction occurs in about 1 in 1,500 pregnancies, whereas in women over the age of 45, it increases to about 1 in 25 pregnancies. More rarely, it can be caused by Robertsonian translocation, which I'll talk about soon, or Down mosaicism, which is when non-disjunction occurs very early in embryogenesis, rather than during gametogenesis, so it only affects some cells. Down syndrome can be diagnosed during pregnancy using ultrasound in the first trimester, on which a fetus with Downs will have what they call increased nucleotranslucency. And what this means is how wide this translucent, or black area is here, at the back of the neck. So that's done during the first trimester, and in the second trimester, you can diagnose Down syndrome using what's called a quad screen of maternal serum, since you test 4 things, which are alpha-fetoprotein, beta-HCG, estriol, and inhibin A. If the baby has Down, alpha-fetoprotein and estriol will both be decreased, whereas beta-HCG and inhibin A will both be increased. Edwards syndrome is the next most common trisomy after Down, with a prevalence of 1 in 8,000. It's much more severe than Down syndrome, and patients have severe intellectual disability, rocker bottom feet, small jaws and low set ears, clenched hands like you can see here, a prominent occiput, and congenital heart disease. These babies are usually born alive but die within 1 year of birth. On the quad screen, maternal serum is usually low for all 4 of these markers, although inhibin A can also be normal. The least common trisomy is Patau syndrome, which occurs in only 1 in 15,000 pregnancies. They have similar findings as Edwards syndrome, such as the rocker bottom feet and congenital heart disease. However, they also can be distinguished from Edwards because they have small eyes and a small head, extra fingers, which you can see here, a cleft lip or palate, and in some cases holoprosencephaly, which is when the prosencephalon fails to develop into 2 hemispheres, which can cause fusion of bilateral structures such as the eyes across the midline. Babies with Patau syndrome usually die soon after birth. For this one, we won't use a quad screen in the 2nd trimester, but in the 1st trimester, you'll see low beta-HCG and low PAPPA, which, by the way, you would also see in the 1st trimester during Edwards syndrome, and also an increased nuclear translucency like I showed you in Down syndrome. Alright, this will be the last flash quiz for this section. So what is the trinucleotide repeat sequence in Fragile X syndrome? This is CGG, and I know it may seem like an obscure fact to memorize, but this is one of those things that if you take a few minutes to drill it into your brain, it can really help you get some points on test day. A chromosomal translocation is the exchange of genetic material between non-homologous chromosomes. So in this image, the yellow chromosomes are homologous with each other, and the blue chromosomes are homologous with each other. So let's say the yellow chromosome represents chromosome 14, and the blue is chromosome 21. A translocation can be either reciprocal or a non-Robertsonian translocation, in which actual DNA fragments are exchanged between the 2 chromosomes, or a non-reciprocal or Robertsonian translocation. Reciprocal translocations can happen between any chromosomes. In this figure on the left, a reciprocal translocation occurred between the bottom half of the arms of these 2 chromosomes, which results in the bottom half of the blue one becoming attached to the yellow one, and the bottom half of the yellow one becoming attached to the blue one. This is a balanced translocation because no genetic material was gained or lost, and this will often have no phenotype for that person, but it can lead to miscarriages or abnormalities in their offspring, since their offspring will no longer be balanced. For example, they might get this part yellow, part blue chromosome from their dad, but a fully blue one from their mom. So they'll only have half of a blue chromosome and have an extra half of a yellow chromosome. This is often not viable, thus the miscarriages. Robertsonian translocations can only occur between 2 acrocentric chromosomes, which are chromosomes that have their centromeres near the end. These are chromosomes 13, 14, 15, 21, and 22. It involves the replacement of the short end of one chromosome with the long end of another one, which results in one chromosome with 2 long arms and another with 2 short arms. This smaller one usually gets lost because it's so small. Since the short arms don't contain a lot of genetic material, this is usually not a fatal loss. Down syndrome can occur if the long arm of chromosome 21 is translocated to join up with the long arm of chromosome 14. If this occurs in the germline and is passed on to an embryo, the offspring can end up with 2 normal chromosome 21s and an extra copy attached to chromosome 14, which is basically the phenotype of this person on the right. This results in a total of 3 21st chromosomes causing Down syndrome. So what would happen if you end up with an extra copy of chromosome 14? This would cause a miscarriage since trisomy 14 is non-viable. Cri-du-chat syndrome, which literally means cry of the cat, is a congenital syndrome resulting from a microdeletion on the short arm of chromosome 5. And the different genes that are deleted are responsible for the different phenotypes of this disease. Alright, so when should you suspect this? Well, first of all, when they're young and they're crying, these patients make a sound like a cat, thus the name Cri-du-chat. But this goes away by the time they're 2 years old. So you can also recognize these patients by some of the traits you can see in this time course. And the most noticeable are a small head and a small jaw, which make the top teeth appear to stick out. These patients also have intellectual disability, a relatively high prevalence of ventral septal defects, and epicanthal folds. which are sometimes hard to see, but it's basically the fold of skin in the medial part of the eye. Williams syndrome is due to a different congenital microdeletion, this time of about 20 genes in the long arm of chromosome 7, which includes the elastin gene. It's often first diagnosed while doctors are investigating a heart murmur soon after birth, since infants often have aortic stenosis. Some physical features that often contribute to the diagnosis are a flattened nasal ridge, a long philtrum, which is the fold of skin between the nose and the mouth, and a wide mouth, although these physical symptoms are variable. They're also described as having distinctive elfin facial features, although I guess this depends on what you think an elf looks like. As they develop into children and adults, you'll notice intellectual disability, but at the same time greater verbal skills, and extreme extrovertedness, to the point that some people have described the personalities of people with Williams syndrome as being the opposite of autism. Lastly, these patients have a variety of other defects, but one of the most noteworthy is hypercalcemia, which is caused by increased vitamin D sensitivity. So how do you think the diagnosis of Williams syndrome is confirmed? Usually using FISH, or fluorescence in situ hybridization. Speaking of FISH, as I told you in the genetics section, it can also be used to diagnose 22q11 deletion syndromes. As a review, on the left here are normal cell nuclei with probes at different chromosomal regions, and the red probe is for the region of 22q11. This is why you only see one red spot on the right instead of two, because the right is showing patients with the deletion in this region. Deletions involving chromosome 22 at q11 can lead to several severe symptoms due to dysfunctional development of the third and fourth branchial pouches. So what do the third and fourth branchial pouches do? Well, as we'll talk about in the reproductive chapter, the third branchial pouch develops into the inferior parathyroids and the thymus, and the fourth branchial pouch develops into the superior parathyroids. The variable presentation of this syndrome includes cleft palate, abnormal facial features, thymic aplasia, which causes a T-cell deficiency, cardiac defects, and hypocalcemia secondary to parathyroid aplasia. You can remember these using the mnemonic Kesh22. Now, DiGeorge syndrome includes thymic, parathyroid, and cardiac defects, while velocardiofacial syndrome includes palate, facial, and cardiac defects. Alright, let's wrap up the genetics section with a step 1 style question. So, a concerned mother brings her 5-year-old child to the pediatrician's office. She explains that the child has been healthy since birth, but has recently begun to have difficulty standing up. The child has very large calf muscles, and he is diagnosed with a genetic condition. Which disorder shares the same inheritance pattern? So like a lot of questions on the step 1, this requires 2 steps to figure out. The first step is diagnosing the condition, and the second, in this case, is picking a disease with a similar inheritance pattern. So first of all, what disease does this patient have? Well, the real giveaway here is the very large calf muscles in a child, which should really make you think about muscular dystrophy. The fact that the patient is a male and is 5 years old will confirm this diagnosis, and further suggest that this is Duchenne muscular dystrophy. Alright, so what's the genetic cause of muscular dystrophy? A mutation in the dystrophin gene. And what's the inheritance pattern? This would be X-linked recessive, which is why you pretty much only see it in males. Alright, time for the second step. So which of these diseases is X-linked recessive? This would be hemophilia A, which is answer choice C. So I know it's not something we covered in depth in this section, but hopefully you've seen this before, and it is mentioned in our list of X-linked recessive disorders. You can also use process of elimination for a question like this. So what are the modes of inheritance for these other diseases? Well, cystic fibrosis and hemochromatosis are both autosomal recessive, whereas Marfan syndrome and neurofibromatosis are both autosomal dominant.